All right, so I went ahead and got some bones for this part. I think it's just easier to use bones. So what we're going to need to do is, there's really no easy way of doing this, but what I suggest is just turn to page, is it 172 in the book? And there's a table there, and it's like an introduction to terminology or terms or markings or something on the lines of that, 172. So these terms are going to be terms that are going to come up time and time again. So let's familiarize ourselves with them. So we have broad categories. We have these elevations and projections. We have processes formed where tendons and ligaments attach. Those are going to be pretty important. Processes formed for articulation with adjacent bones. Okay, so joints. Okay, depressions and openings. And we'll just talk about them. And then I will actually, there is a little picture in the book, but I'll kind of show you on some bones here as well. So let's start at the elevations and projections. So you have what's known as a process. And what is a process? It's just a projection or a bump, right? That's all it is, just a projection or a bump. I mean, there you go. A ramus. What is a ramus, however? An extension of a bone making an angle with the rest of the structure, right? What do I mean by that? Well, let me give you some examples. So here I have a part of the pelvis, okay? And I have this part of the pelvis coming out, making a okay, there's an angle here, right? And this is called the pelvic ramus here, okay, or ring, all right? So you have a ring-like structure here, okay? So you have this. Where else do you have rami, okay, or plural for ramus? What other area of the body? Yeah, you also have right here, right? What's this bone down here? The mandible, right? Look at this, right in here. You guys see that there? Right in there as well, yeah. All right, so that's a ramus. The classic area where you have the ramus or ring-like projection is in the pelvic area, though. Okay, the pelvic rings. All right, so let's move on to where tendons and ligaments attach. So anywhere where you have kind of rough-looking extended areas of a bone, specifically a long bone, there's a pretty good chance that either some sort of tendon or some sort of ligament is going to attach to that bone. Okay, so the first one is what we call a trochanter. Okay, and a trochanter is a large, rough projection. Okay, so here I have a femur for you guys. Okay, and right here I have this large, rough, irregularly shaped area right here. Okay, this is called the trochanter. So I'm going to have, in this case, multiple tendons and ligaments attaching there. Okay, does that kind of make sense? So that's a trochanter. It's a very large projection there. Now, a smaller kind of a rough projection, okay, not as noticeable as a trochanter, is what we call a tuberosity. And you might see a tuberosity on the humerus, for example, and you kind of have this smaller projection right here that kind of comes out a little bit, but it's a little rough, but not too bad, okay? And I believe that this is outlined in your book as well, that tuberosity there, okay? So it's just smaller. It's certainly not as noticeable as this large projection that you see on the femur here, right? The trochanter of the femur.
So is it along the tuberosity? Is it along all sides?
Not necessarily, yeah. Not all bones, not all long bones will necessarily have a noticeable one.
When you turn that in many different angles, if you turn it around, it looks as if it could be on.
Well, do you see that right there?
Oh, okay.
See how that's really distinct from the rest of the bone? If you look at the rest of the bone, this is kind of a distinct little feature that comes out of it. You guys see that there? Okay. It's distinct, but certainly not as distinct as this right here, right? The trochanter. Okay. A tubercle is just a small rounded projection. Okay, so it's a little more round, and actually, I believe you have that on your humerus as well, right here. You have your tubercle here, a small round. See how it's round? And see how this is not round at all. It's very large, prominent, and see how that kind of has a round appearance on it compared to this here, okay, on the humerus. You see that right there? Kind of a smaller, rounder, but you can definitely see that there's going to be stuff that can attach there, okay? A crest is a prominent ridge, and the classic area where you see that is on the pelvis. We call the iliac crest there, right? Prominent ridge there, okay? All right. A line is just a very low ridge. For example, right here, right? Smaller, lower ridge. Okay, that's a line. Okay, that's a crest. It's very noticeable there, right? And then we have a spine, which is a pointed or narrow process. Okay, for example, you've got these little narrow, pointy things that come off, okay, of your vertebrae. Okay, what we call a spinous process. Do you guys see that? It sticks out. Okay, and each of certainly your cervical or your cervical and thoracic and lumbar vertebrae have a noticeable spinous process that extends out on the posterior surface there. Or you guys see that okay there? All right. All right, so moving on to processes formed for articulation. So now we're talking about movement, okay? So what's the head? Well, it's just an expanded articular end of the epiphysis, okay? And easiest place of looking at that is on the femur, and here you have the head of the femur. And then you have your articular surface, right? It's smooth, and generally it's going to be covered in what kind of connective tissue? Hyaline cartilage, right? Okay, so you have your articular surface. So that is known as the head, right? And then what connects the head to the epiphysis? A neck, right? And so you see it narrows down a little bit here, and then it goes into the epiphysis. So you have the head, and then you have the neck here, right? Does that kind of make sense, right? And so so what you can do is when you start looking at, like if a patient has a fracture, they may say a fracture through the head, right? We're talking about that, or a fracture through the neck, through that as well. And so that allows you to kind of visualize or go, okay, I know where this particular injury or this particular problem is. All right, now you have a condyle. This is a smooth, rounded surface, and I'll go back to the humerus here. And so you see how this is rounded and it's smooth. It does not project out like a head like you see on the femur, but it's smooth and it's rounded. And then this is actually where you have the radius and the ulna come in and articulate with the humerus here, right? You guys see that there? Okay, again, it's all articulating. We're talking about joint, about moving, okay? A trochlea is a smooth groove articular process. It's kind of pulley-shaped. And we'll talk about that in a little more detail, actually during the lab. So I won't talk about it in a whole lot of detail here. And then you have what's called a facet. And a facet is just a small, flat surface. Common area where we have these are right here. You see this flattened area right here on this vertebrae here? Okay, and that allows that vertebrae to articulate with another vertebrae. Okay, and that's actually what we call the facet joint of the vertebrae. And some of you may have heard of like certain types of back pain that may involve these joints, inflammation of the facet joints right there. Okay, it's just small, kind of rounded, and you have, that's where your vertebrae actually articulate, where they can move like that in the little facet joint. Because this large round surface here, is this an articulating surface? Is there a whole lot of movement here in between these large? No, there's a big piece of cartilage that fits in there, right, that cushions it. But the movement is actually behind there, right in here, in that facet joint. Okay, does that make sense? Here, okay. All right. Depressions, you have two different types of depressions. You have what's called a fossa, okay, and then you have what's called a sulcus. So a fossa, is a shallow depression. Okay, and you can see here I have a kind of a shallow indentation or depression here. Okay, just underneath or just inferior to the iliac crest. You can kind of see that depression here. Okay, so that would be an example of a fossa. And then a sulcus is just a narrower kind of groove-like depression. And then finally, openings. Okay, openings. So the first one is called a foramen or forama. Okay, forama if we're talking about multiple ones. And a foramen is a large rounded passage. Okay, and probably one of the easiest ones to identify is what's known as the foramen magnum, which is big. It's the big foramen, and that is what actually allows the spinal cord to enter the skull. And so you see this large round hole here. Right here, this is called the foramen magnum, and this is where the spinal cord comes out of the base of the skull there. Right? You guys see that there, the foramen magnum. Okay. The next one is a canal, and this is a little duct or channel. And then you also have what's called a meatus, which is, it gets a little convoluted here, and there's a lot of nuance, so don't worry about the nuance so much because a lot of these have very similar meanings. You have a meatus, which is kind of a passageway through a bone. Again, generally involves either nerves or blood vessels. Okay. You have fissures, which are, again, it's kind of elongated cleft or slit, and then you have sinuses, and sinuses form kind of an air-filled chamber, and it pops open. And so, I don't know if you can see, but in here, okay, under this bone here, you actually have hollow chambers, okay, and these are called your sinuses. You have what are called maxillary sinuses and ethmoid sinuses, okay, and these are air-filled chambers within the bones of your skull where air comes in, it gets filtered, it gets warmed, it gets humidified. You have sinuses in other parts of your body as well, but those are, pretty easy to identify. An example, a classic example of a meatus, okay, an opening, is what's known as the external auditory meatus. This is where the nerve of hearing, okay, exits the skull, and you can see kind of if you feel your jaw, okay, where you have your jaw that connects and articulates here. Just behind that is your ear hole, right? And you guys can see that external auditory meatus right there. You guys see that there, that hole there? Have one on each side of the skull. So there's an example of a meatus. Okay. A foramen, an example of a foramen would be, do you guys see these little holes here? What bone is this again? This is the mandible. Do you see a little hole here? And do you see a little hole here? You guys see those? Okay. Those are actually examples of what we call the mental forama, or a mental foramen. They're a little hole. And you actually have vessels and nerves that come out of those holes that supply this area of the face, primarily with nerves, with sensation, motor sensation. All right. And you can see that it goes through here and actually comes out.
Is it the same with the other ones on the top?
Yep. These little guys here as well. Yep. Absolutely. All right. Does that kind of make sense? You guys okay with that? Okay, cool. I wish that I had some fancy way, some mnemonic or something I could throw at you for memorizing, but I don't really. So that is about as good as it gets, is just actually showing you some examples of these markings. Okay. So there you go. And we'll be talking about them in a little more detail when we get into lab, certainly. Okay, so there's just a couple more things I want to talk about, and that is fractures. Okay. So what is a fracture? It's a break. Now, so if you fracture a bone, you break a bone, right? So, and I know occasionally what I've heard is I've actually had patients that I've taken care of. They come into the ER, and I go in, and they're all happy. I'm like, what's going on? Oh, the doctor told me I just had a fracture. It's not broken. I didn't break my bone. Okay. So, yeah, a fractured bone or a broken bone means the same thing, right? Okay. But yeah, for some reason, I've run into that in a lot of cases where some people think that a fracture is somehow not as bad as a break. Right? If you fracture a bone, it's not as bad as a broken bone. It's the same thing, right? Now, there are different types of fractures or different types of breaks you want to be familiar with, okay? And there's actually just a really good picture of some x-rays, and we'll just kind of go through them. So a transverse fracture or transverse break, it starts on page 190, okay? It just goes right through the bone, okay? It transverses the bone. It's very linear, okay? And generally, if it's not in a critical area, it's relatively easy to deal with, right? You do what? You splint, right? Don't move it, and then you allow 4 to 6 weeks for healing to occur, and generally it's not a big deal, okay? Now, what can happen is, however, that fracture, if there's enough force, okay, it can become what's called displaced, right? And a displaced fracture is a problem because you're not going to have good healing, right? You're not going to have good healing. And what can happen is if it gets really displaced, then what will happen is the muscles will contract, and then those broken ends that are displaced will get kind of pulled in toward each other like this. And you'll actually get what's called shortening of the extremity where the fracture happened. And so what we sometimes have to do is we have to go in and we have to pull that back into its anatomical position and realign that displaced fracture and make it more of a transverse. Sometimes you can do that manually by pulling on it, pulling it out, and getting it back in its anatomical position. Sometimes we have to do it surgically as well, or we do rods and screws. It just depends on kind of the situation and how things look. Another type of fracture is what we call a compression fracture, and that is due to compression forces that push and squeeze the bone down and it cracks or breaks. A common area, the most common area for compression fractures is going to be your vertebrae. Okay, this is commonly where we see compression fractures, where you load the vertebrae, okay, you fall down, you have some twisting, you have some sort of compressive force, and you can cause fractures to different areas of the body or different areas of the vertebrae. And actually, that's what you're looking at there, is a compression fracture of, looks like a lumbar vertebrae, in that picture there. Okay, you guys good with that so far? You also have something called a spiral fracture, and that is where the fracture spirals up the bone. It kind of makes a circular spiraling kind of pattern, okay? Those may or may not be real problematic, okay? If you have a spiral fracture with significant displacement, that can be a problem, right? Getting that to realign. Let's see, you have an epiphyseal fracture, which goes through where? Goes through the epiphyseal plate. Now, in the adult patient, that may not be a huge problem. What kind of patient is a fracture through the epiphyseal plate potentially going to be a problem? Pediatrics, right? Yeah, kids. Now, sometimes it's not as big a deal, but it can be. It can compromise that growth plate, and it can cause problems with bone growth and proper ossification. Okay. You can have what's called a commuted fracture, and a commuted fracture is a fracture where you have significant, not only do you have a fracture, but you have fragments. You have significant bone fragments everywhere, and it's just kind of burst up and fragmented and a mess. That's what a commuted fracture is. It's a mess.
Broken glass. Broken glass.
Kind of looks like broken glass, yeah. But as you might imagine, pretty significant force involved in that. You have fragments of bone. Generally, we've got to go in and surgically correct these things, get it realigned, and you don't want to have little bone fragments floating around. and then they calcify in areas where you don't want calcification to occur. It can be a pretty big problem, okay? Now, there is a special type of fracture known as a green stick fracture, and this fracture is common in kids. And what a green stick fracture is, if you ever like pulled a branch off of a tree that was very green, right, hadn't dried out, and when you tried to break that, what happened? It just bends and then breaks a little bit, not all the way through, right? It just kind of, yeah. So when you bend that branch over, you get something like this, right? Where it only partially breaks, right? That is what's known as a green stick fracture. It's like you have a green stick that you tried to break over, and the whole thing didn't just, like a dry stick, right? Nice dry stick that's been out in the sun, you just bring that thing over, crack it into two different sections pretty easily. Okay, so green stick fractures are common in kids. Why? Why are they going to be more common in kids and not adults? More cartilage. There you go. Yeah, kids have much more cartilage. It's much more bendy. And cartilage is not prone to breaking like the hardened matrix of proper osseous tissue. Okay, let's see here. Achilles and Potts fractures. These are more specific to like your hands. And there's not a whole lot there I'm going to say about those. We've talked about the major ones. Definitely green stick is one that you want to be aware of. Okay, how do fractures heal? Well, they heal a lot like the integumentary system. The first thing that happens is, well, that needs to happen is what? Inflammation. Even before inflammation. There you go. Hemostasis. You need to have blood clotting. All right. So you have bleeding, right? Because as you fracture, you're going to compromise, right? You're going to compromise these vessels in the perforating canals, right? And in the central canals, and they're going to bleed. They need to clot. So you have a clot that develops, right? And then what happens is you have those progenitor cells, right, that exist within the endosteum. Some of those cells also come from the periosteum, right? Those cells begin to infiltrate the area. You do have an inflammatory response. So you have a rush of blood and nutrients and white blood cells that come into that area. Okay, so you have inflammation. You have osteoblasts that are activated that move into that area, that begin rebuilding that matrix. And then what happens is, as that fracture heals, ultimately, in a lot of cases, where you have that fracture actually heals very robustly. It's very strong. And a freshly healed fracture, okay, if you look at a fracture after, say, 6 or 8 weeks, what you often might see is like a callus that develops, a kind of a bulge in the bone, where you have kind of this overdevelopment of bone there, right? Now, generally over time, and with bone remodeling, over time that callus kind of gets fine-tuned, and it gets, to where you could look at that bone and you couldn't tell that there was a fracture there. But initially you may have that callus develop there. In some cases that the fracture site tends to be a little stronger than it was before, and so people that fracture in one area are not necessarily more prone to refracturing that area, because you do get that real robust, growth. However, there are some problems that develop that make us much more prone to fractures, and probably one of the most pressing problems is something known as osteoporosis. Okay, and osteoporosis is something, it results from a process known as osteopenia. Okay, just like leukopenia or pancytopenia deals with low white blood cells or all blood cells being low. Okay, what does osteopenia literally mean?
Inadequate osteophytation.
There we go. Inadequate osseous tissue formation. Right? Now, unfortunately, this is normal. Okay, this osteopenia is normal, And it happens a lot sooner than you might imagine, right? We actually start seeing noticeable changes by the time you're about 30, right? So probably a lot of you guys are okay, right? You're still in your 20s. Some of you, and unfortunately myself included, once you cross that 30 threshold, you actually just start normally losing bone density as you grow older. In general, is it more pronounced in men or women? In general, it's a bit more pronounced in women, okay? Now, in severe cases, and this is particularly with a spongy bone, we can see it, this can lead to something known as osteoporosis. And what is osteoporosis? What differentiates that from just osteopenia?
Spongy bones?
It's like the decay of it.
Well, what is osteoporosis, though? I mean, it's in the book, so let's just make sure that we understand how that differs from osteopenia. Because they're related, but there's some difference there.
It's the reduction of bone mass.
Okay? But it causes what?
Loss of spongy break.
Okay, good. You lose bone, and it is dysfunction. It is osteopenia to the point of dysfunction, where the bones are going to be prone to fractures. In some cases, it can get so bad you can develop spontaneous fractures, where you may just get up. You may just get up out of your chair, and your hip spontaneously fractures without any other trauma. And that's really a big concern when it comes to osteoporosis, because what happens when you fracture your hip? And we see this a lot with elderly patients. This is a big killer of elderly patients, actually. You got to get your hip replaced, more than likely, right? Because, and now with me, if I'm, let's say I'm a healthy guy and maybe I fracture my hip, there's minimal displacement, they may just keep the original bone there, right? But if I have diseased, dysfunction bone, what are they going to have to do if I fracture my hip or I fracture the head off of my femur? Well, they're going to have to take that off, and they're going to have to pound a metal one in there, right? They're going to have to replace that. They're going to have to do a total hip replacement, which means surgery, right? What's a problem with being in the hospital after surgery? Infection is a huge problem, right? The last place you want to be when you're sick is where? The hospital. In a lot of ways, there's some truth to this. Some people have complained that, trying to get people out of the hospital soon, that's all about money, right? The hospitals, we're greedy and we need money. Well, yes and no. The reason that there is a big push to discharge patients as soon as possible is every day you stay in the hospital, your risk of getting a very bad infection goes up and up and up. You are actually better in your dirty, filthy home, okay, than you are in the hospital, right? The germs, the bacteria, and you're used to that. Your body is used to that. Your microbiome in your body is used to those bacteria. But when you go into the hospital, what kind of bacteria are you dealing with in a hospital? Yeah, okay. You're dealing with some real ballers, okay? You're dealing with some bacteria they're not joking, okay? Because you're giving lots of antibiotics in the hospital, right? Yeah. And so these bacteria are often highly resistant, right? And there are some really bad types of infections. Are you guys familiar with what's called MRSA?
Yeah.
What does MRSA stand for?
Methicillin-resistant staphylococcus.
Yeah, methicillin-resistant Staphylococcus aureus. So methicillin is kind of a last line antibiotic. Like with penicillin-based medications quit working, cephalosporins and all that, we go to methicillin. What happens when methicillin doesn't work?
Can you give vancomycin?
We have vancomycin. And then there are even what we call VRE, vancomycin-resistant enterococcus, okay? And then there are a couple of newer antibiotics after that, and guess what? There are now infections that we have no way of treating. Okay, so if you go in the hospital and you get a pneumonia that cannot be treated, sorry for you, right? Hopefully your own immune system will take care of that. But if you're 70 years old, you have osteoporosis, you have some other underlying problems, and now you get pneumonia on top of your hip replacement, that's a death sentence, right? And this is a big killer among elderly patients. They get a hip fracture. It's not the fracture kills them, it's the infection that they develop, right? So this is a big problem, right? Is how do we prevent infections in the hospital? Because our antibiotics are rapidly becoming, and in some cases are completely ineffective. There are, and I know I've talked about this multiple times, that the onus is on you guys now to kind of grab the torch from us and find new and novel ways of dealing with these. One of the novel ways that we're dealing with some of these infections is actually something called a fecal transplant. You guys ever heard of that? There's a type of infection called C. diff, Clostridium difficile. It is an infection of your intestines. It is drug resistant. Oftentimes we cannot effectively treat it, and it can cause life-threatening diarrhea. What we have found is, if you take fecal matter from a healthy patient and you put that into the diseased patient, that fecal matter, the bacteria in that healthy fecal matter will be able to compete with the C. diff, and in a lot of cases the infection will go away. And so fecal transplant has become one of the new standards of care for treating people with C. diff, where they get C. diff, what you'll do is you'll find a healthy person and you will take a big sample of poop from them, basically, from their intestines, and then you will inject that into the intestines of the sick person. It's called a fecal transplant. And the cure rates are actually very high with this technique. They've started doing them here in Las Cruces even. It's a big problem. A lot of people get this type. So there's some real out-of-the-box thinking that's needed to deal with some of these problems. Okay, so we have talked about all the relevant material that we need to for Chapter 6. How about we move on to a review for your first exam? What do you guys think?
Yep.
All right, let's do that. Okay, so first exam. It's going to be part of it's going to be multiple choice. You're going to have 40 multiple choice questions. Each question will be worth 2 points. So that's 80 out of the 100 points will be multiple choice, A, B, C, D. So the first 40 questions you will answer on your Scantron. Okay, A, B, C, D. Okay, fill it in. Okay, so far so good. You will have 5 essay questions. Okay, and they'll be worth 4 points a question. And so that'll give you a total of 100 points. Okay. Now, the cool thing about that is the essay questions, it's not an all or nothing thing like a multiple choice. So if you get some of the relevant material in the essay question, you'll get some of the points. So it's a trade-off, right? You know, yeah, it kind of sucks having to write and maybe even draw, right? You can draw pictures too as well. I don't mind. It's easier. Okay. So that's how it'll work. You'll have about an hour. Okay, you guys will come in. Your phones need to be off. Okay, if somebody's phone rings, yeah, I will ask you to leave, and I'll just assume that there's some academic dishonesty that occurred there. You'll take a 0 for that exam. So just turn your phone off. Show up on time. If you show up late, sorry for you. That's 10% of your grade, right there. Okay, unless there's some very legitimate reason, right? And you need to let me know as soon as you can if there's some issue where you can't be here, and we can look at getting the test. Following the test, I'll have to go right into lecture, so I will not be able to review the test right away for you guys because we still have a lecture that we'll need to get through. So probably will not be able to review the test until either lab or the following week, okay? Because I can grade the Scantrons right away, but it'll take me some time to grade the essay. Okay, but we'll do that. So that's the general. That's generally how it'll run. So make sure you show up on time. Make sure you turn your phones off. It's okay. You'll be okay for an hour without texting. Or seriously, okay. The first 20 some years of my life without texting, and it turned out okay. So just.
Does it start at 5:30?
5:30.
Like a normal class?
Normal class, yeah, 5:30. Yeah. All right. Now, nobody has given me there's if you have a learning issue, there are things that happens with the student learning disabilities office, the SAS office, and if you have a memo, you need to get that memo to me as soon as possible, so whatever accommodations need to be made can be made, but you can reference the syllabus for that. So let's go ahead and just do a quick review of some of the things that you'll want to focus your studies on. Okay, so chapter 1 through 6, right? So what's chapter 1? That's primarily terminology, right? Anatomical terminology. So some of the things you want to look at body planes. You want to look at the organization, right? So we start at the atomic level, and we have different levels of organization that become more complex from there, and all the different emergent properties that come out of more and more complex levels of organization. You want to be familiar with basic terms, anatomy, physiology, cytology, histology. Okay, just some of the basic terms that we've gone over. Obviously, that includes things like anterior, posterior, dorsal, ventral, right? Superior, inferior. Okay. You should be really comfortable with all that terminology. You guys okay there? Okay, chapter 2 is that chemistry, right? It's the chemistry of life there. Okay. So again, you're going to want to be familiar with some of the key concepts that we've talked about in chemistry. Okay. What are atoms made of? Okay. What are the major types of chemical bonds? Okay, covalent, ionic. What are some major types of intermolecular bonds, hydrogen bonds? Okay, what is responsible for hydrogen bonds forming, right? We talk about electronegativity differences. And how do these different chemical properties, how does this reflect to how certain molecules work, right? We have polar molecules, we have nonpolar molecules, right? And that's very important when it comes to solvents and solutes and how things get dissolved. You want to be able to identify major chemical reactions. Specifically, I would focus in on synthesis reactions and decomposition reactions, right? Okay, so when for example, when I make polypeptides or when I make polysaccharides, right? These are synthesis reactions, and these involve dehydration, right? And then your breakdown, your decomposition reactions often involve hydrolysis, right? So dehydration, you pull a water molecule out to make a bond, or you break a water molecule up to break the bond. Let's see here. Definitely, yeah, we talked about that already. Okay, pH. You want to be comfortable with pH. What is that all about? What's normal? What's acidotic? What's alkalotic? What does that mean? What are you measuring? Let's see here. You need to know a little bit about the major macromolecules of life, right? What are they? What are they responsible for? How are they produced? Specifically nucleic acids and proteins. proteins have different levels of structure, they have special shapes, and there's some terminology that you want to be familiar with around that. Okay, what are the roles of these macromolecules? Like what do proteins do, right? What do nucleic acids do? What do carbohydrates do? Okay, what are high energy phosphate molecules? How is ATP produced? You're going to want to know that. You're going to want to know the 3 cycles that are involved. Which ones are anaerobic? Which ones are aerobic? Where are they located? What's going on? How is that ATP being produced? Okay. The disorders that I've talked about, you're going to want to know them not in specific detail, but you're going to want to know, okay, this involves connective tissues, this involves the lungs, this involves that, okay, just in general, you know, so like Marfan syndrome, osteogenesis imperfecta. When we talk about the pituitary dwarfism, we talked about today, acromegaly, you know, some of those things. Okay, cytology. Okay, you're going to want to be able to identify different organelles and what those organelles do. How stuff gets in and out of the cell. What are special characteristics of the cell membrane? What makes it special? Different types of transport. Okay, diffusion, osmosis, active transport, all that good stuff. Isotonic, hypertonic, hypotonic. We talked about all that. Okay. Histology. You can have several questions on histology. Okay. Right. So you're going to need to be able to identify the major tissue types. Okay. So connective tissues, right, and then different subtypes of connective tissues. Is it connective tissue proper in general? What do these things do? Cartilage, osseous tissue, blood. Okay. Epithelial tissue. Okay, what types of epithelial tissue, where or what areas of the body are different types of epithelial tissue found, right? You know, what are characteristics of epithelial tissue, right? We talked about them being, they're avascular, they have a basal lamina associated with them, they're tightly packed. Connective tissues tend to have spread out cells that are embedded in an extensive extracellular matrix, lacunae, right? All those classic things. Muscle cells, right? You have 3 different types. Each type has different characteristics associated with it. Blood, right? And there are different blood cells, right? You have red cells, white cells, thrombocytes, different types of white cells. Okay, you don't have to know what they do specifically, but you have to know generally, you know, what is what's going on there. Okay. Let's see here. We talked about cell division, right? You should know that in some detail, right? Specifically, you know, all the different phases of the M phase of mitosis, of you know, what's going on interphase. Okay. Let's see, we talked about the integumentary system as well. Okay, you should know the layers of the epidermis. You should know some of the significant proteins that are involved. Okay, there are some very specific proteins and vitamins that we've talked about that are significant to the integumentary system. What role do cleavage lines play in healing and we talked about chemistry already, I think, right? The atom and valence electrons and periods versus groups and what's going on there. Okay. And then that brings us to osseous tissue. Okay. You should be able to identify the macroscopic and microscopic structure. You will not be identifying highly specific or nuanced bone structures, right? Like, I'm not gonna, what is that right there? Right? What is that right there exactly? You're not going to need to know that. But you are going to need to be able to identify what are some long bones. Okay, what are some examples of long bones? What are some examples of short bones? Irregular bones, flat bones, sesamoid bones, those kinds of things. What are some examples? That's all, right? Doesn't need to be any more detailed than that. Okay. This, though, you'll want to be very comfortable with the microscopic anatomy of compact and spongy bone, right? The lamellae, the lacunae, okay? The trabeculae of the spongy bone, the cannulici, what's going on there, okay? The periosteum, right? Periosteum connects, right? Connects to the compact bone with these perforating fibers, these collagen fibers. So it's really strongly connected there. Okay, so that kind of stuff there. Okay, that's okay. We talked about that already. Okay. What makes water special? I know that in detail.
What
Where
makes water work?
water, yeah.
It's conductivity, is that what you mean?
No. There's some very special stuff we talk about with water in particular, right? Why is it so important when it comes to life? What's going on there, right? We talked about that in some detail. Diffusion, definitely know diffusion, what goes into it. Okay, what are some of the factors? We spent some time in lab. There's some experiments that you guys did in lab about diffusion. Really important concepts came out of those experiments. I already talked about protein, all the levels of protein structure, shape, and definitely cellular respiration, cell cycle. Yeah. Okay, that's it. Yeah. So if you're comfortable with all the concepts that I just talked about, you will rock it. You will rock it on this test. The exams are open for you guys to review. Those of you that did not take it, I'm going to try to do some playing around, but I may just have to open it for you to take it so you can access the answers. We'll see if I can do that. But otherwise, the exams are up and open, and you can review the questions and answers until Monday. Let's see here. I know it's a little early, but do you guys have any questions? All right. Well, it just gives you a little extra time to focus studying and all that. And, okay. One thing that'll really help you with the lab on Thursday is do as much of the pre-course and the check your learning and all that stuff before showing up, because it's a big one. There's a lot, all bones. But the good thing is, none of that stuff in lab Thursday will be on your test on Tuesday. So you don't have to worry about that yet.